Hi, I'm Dr. McCabe-Simon. I'm a GP registrar heading towards my final exams after 10 years of study, so it's a very exciting time, and I am learning how it is that I want to be practicing going forward as a GP with a long career ahead of me. So this has been such an inspirational day for me today. I stumbled across low carb as a concept in about 2016 as I was heading towards having my first child, looking at the evidence for a healthy diet in pregnancy and breastfeeding. I even brought my 6-week-old to the Low Carb Down Under conference in Richmond in 2019. So he's not here today. He's 2, and that would be a problem. But it's been a great day. So I feel very privileged to be amongst you all, and look forward to future meetings like this.
My name's Dr. Arj Herath, so I'm a GP and I practice in Mulgrave. So my story about low carb comes, I guess, from my own battle with the bulge, so to speak. So I've been up and down in terms of weight since I was in my teen years, and I stumbled onto low carb by meeting up with a friend of mine who I hadn't seen for quite some time, who had managed to get very healthy and very fit within a very short period of time, being on a ketogenic diet, and he had transitioned to more of a carnivore diet, and I was quite amazed. And as a GP who had been taught conventional medicine and very little but conventional nutrition, it was actually very hard for me to believe it and to accept it until I started to do my own research and look into it. And of course, I saw my own results. Now I tend to champion low carb eating. And I understand that it comes in a variety of different ways. So I almost always look at diet as part of my patient consultations, no matter what the issues are. And I've found it incredibly beneficial in gaining health for my patients.
Hi, my name's Barton Jennings. I'm a respiratory and sleep physician. I think I also came into this low carbohydrate lifestyle with a bit of skepticism. It was, I think in 2018, we were going to this gym, and one of the gym owners, Vicky Curiel, who's a dietitian, was running a 6-week low carb challenge, and my wife suggested to me that we should do it, and I said, no, I'm not doing it. I don't believe in it. And she said, come on, we live together, we eat together, we cook together. She does most of it, but we should do it together. I said, okay, that sounds fine. I'm happy to give it a go, and because I'm interested, but I'm going straight back. We certainly never looked back after that 6 weeks. I lost weight, I felt better, and completely changed the way myself and my family now live our life, and has also led to the way I practice medicine. So as a specialist in respiratory disease and sleep disorders, I was really quite amazed how often I'm now talking to patients about low carbohydrate lifestyle and how much it actually helps with their respiratory and sleep disorders and just general health.
Hi, I'm Avi Charlton. I'm a GP. I practice in Wantirna. I've been a GP for about 16 years, so I've had my babies, they're 9 and 12. So after that, I decided that I need to get fit. I joined the gym, and I started running, and I did a 8-week body transformation with my gym. The gym would tell me what to eat. I had to weigh the protein and the carbs and the fat. So that's basically a low-carb diet. So I lost a lot of weight, and I took up running, and I ran a marathon a couple of years ago, having not exercised before. So since then, I looked into low carb. I did more learning. I did the Low Carb Down Under weekend for doctors a couple of years ago in 2019, and then I decided I want to be a low carb GP. So I designed my low weight loss program in my practice. I learned more science, I read more books, and I try to incorporate low carb into my practice, into a lot of the consultations wherever relevant, and I've seen good results, reverse diabetes, women with polycystic ovarian disease reversed it, and they had babies, very satisfying and having lots of fun.
Look, I suppose I had 2 questions. One, I reckon, might be a pass, and they're very quick. The first one is, how do you cope with the accusations of bias? Because I know I've got my own little patter, but when your colleagues come up and say, but you're biased, I'd just love to hear from any or each of anyone about if you have a patter for it, or a response or a standard response. And then the other one is really just seeding a thought about the future of Facebook and its involvement with big food, big pharma, advertisers, and with this privacy coming in. I just get concerned when I see these Facebook groups, because I've actually got off it for reasons that I'm really worried about. I see them as the pathogen, or the microbiome. You're the commensals and the symbiotes, the positive little bacteria trying to get its way in a big organism that's got a lot of cytokines and a lot of armoury at its disposal.
I'm happy to start, and I'm also happy to start by saying I'm not quite sure how to answer that best, but I don't think I've had people say to me that, oh, you're biased. And I don't really see where there could be bias, because, I mean, what is there to gain? I don't see I've got anything to gain from recommending that people stop eating carbohydrates. But I think the most powerful thing for people is to see the change in themselves. And I think that from listening to people's talks today and just our introductions, that everybody, and certainly from my own personal experience, everyone becomes a believer once you see it happen to yourself. And so you might read the studies, you might watch Paul Mason on YouTube, and you might be you're influenced by people who you have respect for. But when you see something happen to yourself, then I think that there's nothing more powerful than that. So I often say to patients, well, maybe, you've tried this and it hasn't really worked for you. You've tried this, that hasn't really worked for you. You haven't tried this, maybe just give it a go. And I challenge you, do it for 4 weeks, do it for 6 weeks. And at the end of that time, see how you feel. If you don't feel better, if you've put on more weight and it hasn't worked, just give it up. And I guess that really comes from my personal experience as well, when I said, no, I'm not only doing this for 6 weeks, I'm going straight back to how I was, and never did. And so I think I found that quite effective for people. Colleagues. Right. Yeah. And at Monash, and a part of the respiratory and sleep department at Monash. And in 2018, after doing the Low Carb Challenge, I invited Vicky Carril to come and give a talk at Monash, because I have to organise the lunchtime meetings for our unit every October, so I have to get 4 talks. The following year, Rod Taylor came along. The following year, Peter Bruckner came along. And I think the first year that people were like, oh yeah, that's interesting, yeah, what a load of rubbish. Rod came along, and I think they heard it again. I thought, oh, there's a bit more credibility. Peter came along, and I think heard it again, and there was a bit more credibility. And having not seen a lot of my colleagues last year during COVID, we're back in the office, and they've started to lose weight. And I've asked them, what are you doing? You look fantastic. And they said, oh, I've gone low carb as well. So they're actually starting to come around. So, but other than that, I guess I haven't really had too much backlash from colleagues and things. I do write letters to GPs, and often in that letter I will say that I recommended that patients go on a low carbohydrate diet, and I always have in the back of my mind, I wonder what that effect that will have on that GP, and if I'm recommending things that are not in tune with that GP's beliefs, am I potentially cutting myself off from a referrer, or maybe altering how they think of me if I'm going out of my respiratory and sleep area of specialty to recommend nutritional change.
On the plus side, as a person who has referred to you, I'd be over the moon to receive that back from a specialist. So it's really got its positives.
Good to hear.
I think my experience with colleagues telling me about their perspective about bias is, I think they are not ready for change themselves. So it's a bit like our patients. You preach, I see about 30 patients a day, and quite a lot of them aren't ready for change. So I tell low carb to 30 patients, maybe I've changed 5. Same as the colleagues. I tell them about the low carb, they see how amazing I've done and how good I feel, but they're not ready to give up their carbs. They're not ready to change themselves. So they need to be ready to change. Maybe I need to tell them another 10 times and maybe they will change. So I think that's when that will come in, when they can ready.
Great. Look, it's a big question, but social media and Facebook and the influence, this is very complicated, but any one of you four got any comments on should we be worried?
I don't think we should be worried per se, but I do think that it is, I think most people these days, they do open up their Facebook and they do scroll and keep scrolling and they see different articles and there's a lot of junk and it comes in, you're sucking it in, your brain is reading it, it's doing positive things and it can do very negative things as well. But I think you need to understand you have to be beyond the simple person who's just reading stuff and taking it all in. You have to be a bit more critical. And as with any kind of, I know that Facebook is probably not new anymore, but certainly as we are becoming more mature and understanding how Facebook works and how it's manipulating us, I think there is a growing tendency not to believe everything you read on Facebook, and I think that's actually where this is all heading. There is the whole business of freedom for people to be able to say what they want to say, and that includes corporations and vested interests and certain agendas being pushed. But at the same time, I think the populace is becoming more educated and understanding that they are being manipulated. So there's good and bad, and just like the rest of the world, the real world, which social media is essentially mirroring, it's now time for us to be able to mature along with it and pick and choose what's real. I think it is an individual choice. We certainly feel a certain way about our community of low carb and what we see and what we believe, but you have to acknowledge that there's a lot of other people that will push right up against us, and there is a bit of a war of words there, and maybe it gets us a bit disgruntled, but maybe it is healthy as well because it challenges us to come up with our own evidence base so that we can push our agenda forward as well.
Thanks.
I love Facebook, so I feel like it's a great way to connect people, and we've got Low Carb Melbourne. I joined Low Carb Canberra. I'm with Low Carb Down Under, and I'm connected to the doctors' Facebook group, and if I have query about low carb, put it on the doctors' group, and I get lots of advice from Lucy and Liz, and I think it's a great way to connect and share knowledge. I want to share all the low carb information. I share it to the GP down under. I get some backlash. The other doctors don't want to know about it. They say low carb's unsustainable, don't want to know about it. But I think the more we tell them, the more we can infiltrate this low carb idea to the general doctors' population.
Hi everyone, thanks a lot for the talk today. It's been cathartic. There aren't many people out there who are interested in this topic, and it's been driving me mad, so I really appreciate this event. And on that, there seems to be an underlying theme that, maybe you'll disagree with the premise, but it seems that doctors tend to be incurious or rushed or in some way not really interested in receiving new information and implementing that in their practice. At least that's my impression. Do you agree with that? And is there something in medical education that selects for a certain type of person or creates a certain type of person, or what's going on? How did we get here? That's my question.
I think medicine definitely selects for a certain type of person and then probably during the university pushes that person to be more the way that they are to be from being selected. I think that is definitely the case.
That's actually a huge question
It is.
because it goes all the way back to what medicine is and the training of doctors through I guess the hundreds and hundreds of years. kind of from a master apprentice kind of a model to, now it's more, we do put a lot of faith in our experts, and there is eminence-based medicine is the way it has been, and a lot of the medical community still goes with that. So there's a lot there, but there's time pressures when you're actually seeing somebody over a 10-minute consultation. You're only able to. I remember going through our GP exams, and one of the key things that we had to do during our OSCEs was to somehow hand over a piece of paper. So that was you got a point for that, to hand over a patient information sheet, because that is what we were supposed to do. You weren't. And we were trained to think that is so important, that this is, when it came to nutrition or these little peripheral bits, that wasn't your job. You refer to a dietitian, nutritionist, somebody else. And I think we've taken that on a bit too much. It's hard. If you're going to be a low-carb doctor, to take the time to slow down, to look at the person who's sitting in front of you as an individual who's going to be different from all the other individuals on the planet. That's hard. It's time-consuming, and sometimes it's a lot easier just to hand over that piece of paper with guidelines. But that is a huge question. I appreciate that, but it is a huge question.
I think touching on the area that you mentioned about doctors maybe not wanting to learn or extend their knowledge and expertise, I think that we're probably trained actually to do that, and I think that that's probably something that we're quite good at in terms of ongoing education and educating ourselves. I think the problem is probably more so in, are we prepared to change our beliefs? Are we prepared to realise what we had done in the past may not be correct? And I think one of the speakers earlier today touched on that, and I think that's probably where we could be better and go into new knowledge with sort of open eyes, thinking I could challenge the way I've done things in the past. I think that's what I think people tend to have difficulty with.
While there's clear evidence for obesity, diabetes with low carb, and that's evidence-based, anecdotally, do you also see improvements in other conditions with the low-carb diet, such as endometriosis, mental health, pain, joint pain, and so forth?
Absolutely. Off the top of my head, polycystic ovarian syndrome, definitely. Mental health. So often they come in and they want a mental health plan, or they want a antidepressant. So quite often I would just say, oh, how's your diet? Maybe if you improve your diet, that might help with mental health. And certainly there is evidence that mental health, depression, anxiety can be helped with a low-carb diet, real food diet, getting rid of junk food. There's Parkinson's disease that's been helped with low-carb diet, in my experience. Many more to come.
I believe there's some evidence around migraine management as well. I've seen that. I'm not sure about the evidence with fibromyalgia, but I've certainly seen some improvements.
And reflux disease, definitely.
A lot of autoimmune conditions. So I think that's another area where the numbers and the data is coming in. But anecdotally, yes, autoimmune conditions. One of the most interesting things for me was a patient with diverticular disease who seemed to have a bout of diverticulitis about every 3 months or so, and his gastroenterologist had recommended a high fiber diet, and he went on a low carb diet simply because he wanted to lose a lot of weight, which he did. But miraculously, his episodes of diverticulitis settled down completely as well. So there are these anecdotal things that seem to be, especially inflammatory conditions seem to be well managed with low-carb diets.
I also wonder about malignancy. I do a lot of work with lung cancer, and we have a look at the CT scan, and the CT scan shows you that there's a lung lesion, and then we'll do a PET scan, and the PET scan tells us whether that lesion is metabolically active, meaning that it has a high uptake of glucose. And I look at this all the time, and I think, well, if we're using this to determine where the cancer is and to determine if the cancer is highly metabolic, when it comes to treating it, doesn't it make sense to take the sugar away? If that's what it's chewing up, like, why don't we take the sugar away from it? And of course, we need to treat malignancy in the traditional ways, and we're not going to treat malignancy just with a low carbohydrate diet. But I do certainly always wonder whether patients would have additional benefit to their treatments if they were to adopt a low carbohydrate diet at the time of diagnosis of malignancy. I think that would be something really interesting to formally study, but very difficult to formally study.
Thanks, Rod. I'm going to keep it very short. How do you think you can break the nexus between the funding of the Dietitians Association of Australia? As I understand it, 70% of their funding comes from the Grocery Council of Australia, food industry, and given that the guidelines they come out with determine what kids eat at school and lunches, what the military is fed, and what happens in residential aged care facilities throughout Australia. That's why they get a high carb diet. The diet they get is dictated effectively by industry. So it just seems to me if you want to get to the root of it, you have to break that. And I'm just wondering, what the thoughts are about how you go about that, if it's possible.
So that's the Australian Dietary Guidelines, which James Milkey has organised the review of the Australian Dietary Guidelines, and there was a submit of survey on how the public feels about it, and me and a lot of other low-carb doctors have submitted a request of what we think is the correct Australian Dietary Guidelines. So hopefully with the review of the guidelines, if it's done to our favour, all those things can change in the schools and military, etc. So I'll write to them. So that's how I contributed.
My name's Sheila. My question is, given the role of insulin resistance, I find it very difficult to get an insulin done if I go into the GP. Okay, I'll go in and I'll ask them to check my bloods, and the last thing they will want to do to me is to check my insulin unless I ask for it directly. Now also, we have we have our routine medical checks when we need to have a mammogram. We get our occult blood when we need to do a stool at a certain age. And to me, it would seem sensible if you can see that somebody is reaching a certain BMI, they should have their insulin level checked, because it will be a precursor probably to their diabetes type 2. And also when people do become diabetic, they need to have their insulin followed, but this never is done. And also we could probably do insulin levels on people that we are suspicious about, which would give us an idea of what's going on. Maybe everybody who is over a BMI of 30 should have an insulin level, and maybe anybody that we think is going into type 2 diabetes should have an insulin level as well.
You're absolutely correct. The interesting thing about this, and this comes from a case that I had just this past week of somebody who's quite young, early 30s, who has mild fatty liver, mildly elevated HbA1c, and their inflammatory markers are a little bit up as well. And so this person has a normal BMI, they're normotensive, there's no family history of cardiovascular disease, and they are essentially they look well and they feel well, and they just wanted to get some bloods done, so we did those. Now, the thing is that most conventional GPs would tend to say that everything's fine, go home, come back whenever. The reality is, though, that some of these little markers, if you're recognizing these things a little bit earlier, you can certainly pick up on them and you can do something about them early. These are the patients that fall through the cracks, and what you're saying is absolutely right. If there's this little suggestion that there's inflammation in the body and there's certainly insulin resistance, well, you need to follow that up, and you need to start to interrogate this situation so that it doesn't lead to the inevitable pathology that's going to come in 5-10 years. You can do something early, and that's what you're saying, is to take an opportunity to do something before it gets worse. And I couldn't agree more. Absolutely. And as far as finding a GP to do your insulin, I think you just need to look in the right places. And if you go to Low Carb Down Under, there's a list of GPs that will probably be supportive of your request. And of course, Diet Doctor if you're looking across the world.
Can I be slightly controversial and disagree? This is also speaking completely out of my area, but in medicine, we should really only do a test if the result of that test is going to alter our management. If someone's BMI hits a certain level or they've got fatty liver disease, is the result of their insulin going to change what our management should be? I would have thought that if we see those things, we don't need to know what their insulin level is if we know what the problem is.
I would agree, but I would also say that a lot of people would look at that and probably not act as urgently or decisively as you would if you saw a significant rise in insulin resistance.
So it could help define the problem and help illustrate the problem and almost show that there is evidence for the problem. So we would say that most of the time, if someone's weight hits a certain level and that they've got fatty liver disease, then these are signs of insulin resistance, and going onto a low carbohydrate diet would be the best management for those situations, irrespective of what the blood test insulin level shows. But having the blood test insulin being elevated gives weight to put behind what the basis of your management.
Yep.
The question is, how do we respond to a pharmaceutical company when we describe and not use them so much? My answer is I don't really get much feedback from pharmaceutical companies, so it doesn't affect my practice. I don't really care what they say.
I do quite a lot of GP talks and things, and some of those are sponsored by pharmaceutical companies. And when I first started doing them, it was great because the pharmaceutical company would organise the talk, they'd put on a dinner, organise the audience, you come and talk. After a few years, they sort of changed. They started to say, here are the slides. You can change them, but here are the slides. And I thought, okay, that's okay. I'll just put in my own thing. And now they've changed even further, and they're like, you can't change the slides. And so, unless you get special permission. So I got special permission to put in a few slides, and I said sent the slides back, and I put some slides in about low carbohydrate and the importance of weight loss in improving breathlessness in people with lung disease. It makes pretty good sense, I would have thought. And I was told that I couldn't put those slides in because they didn't see that was relevant. So I just said, I'm not going to do the talk.
Can I just put in my own 5 cents worth on the insulin situation? So my understanding, Ben Bickman, my good mate Ben Bickman, thanks Ben, and I also heard him saying, he virtually said that he's coming to Australia, didn't he? So we're going to hold him to that, definitely. But now he says that your insulin should be 6 or below. I think the average in the US is 9, but some people can have insulins with a normal glucose. I think the record is 500, right? So I know that's quite an extreme case, but I've heard sometimes the insulin gives you advance warning that although your glucose might be okay, that your insulin is off the planet And this is a very bad sign, and you need to do something about it. So just one or two other little things on insulin. Ken Sakaris says one of the problems with a one-off insulin is it's quite variable because it's a pulsatile hormone. So you take it 1 minute and it's one level, and you take it 5 minutes later and it's another level. But you know, I like the idea that the more information we have about our health, that's good, but you need someone to interpret it. Any comments?
Yeah, so I've just started doing an insulin test over 2 hours with the glucose tolerance test. Then you get an idea of how the insulin goes up and goes down, then it's good, or if it keeps going up, then it's really no good. So it takes 2 hours for the patient to have fasting test. Then they'll get blood test taken, they get a sugar drink, they get the insulin taken fasting 1 hour and 2 hours, or you can take it half an hour, 1 hour, 2 hours. Then we get an insulin curve, which is the better idea on insulin resistance.
Hi, I just had a question for the four out the front and any other GPs that are here as well. Whether you use any technologies like continuous glucose monitors in your practice, and what kind of role that can have for people with diabetes and pretty much anything else as well.
Well, I guess the biggest hindrance has always been cost. So for patients who are especially new to diabetes, and to understand what happens to their blood sugars when they eat a meal and how they fluctuate through the day, continuous glucose monitoring is just brilliant. And it doesn't have to be for the rest of their life either. They can actually do it just for a few months, and they get a really good understanding of how their own body works. And that can be quite motivating and can be very positive in terms of behavior change as well. I'll advocate it if I know that if cost isn't a barrier, but often it is to a lot of my patients.
Yes, I agree. I haven't got much experience on continuous glucose meter. Sometimes telling the patient in the beginning that they've got diabetes, you need to start pricking your fingers, and that's hard enough already. And if you have to tell them to get a continuous glucose meter, it is a lot. So maybe when it gets cheaper and if it gets more accessible, then it might be easier.
Just on that one size doesn't fit all idea, which I totally agree with, what differences have you noticed between men and women with low carbohydrate way of eating? I know it's a big question.
Big difference. The men do it so much better.
I agree.
The women struggle. They do the same diet with the husband, and the husband loses lots of weight. And the women find it very difficult. I guess there's lots of different factors going on there.
So why would that be?
I think it's the emotion.
We're talking hormonal, basically. We're talking a different set of hormones between men and women, and that's essentially what's driving the difference.
And also psychology. I've seen the men. This is a big generalisation, but and very much. I think it was Mary's presentation was there was a man who just did it, and the woman who required the support. But I have just mentioned to men that it's a good idea, and then they've come back and it's done, and that's happened with women, but just. I think it's the psychology behind it as well, the emotional attachment to food.
I think it's really, in this low carb space, I think everybody fills a role as a learner, as a teacher. There are the scientists, there are the practitioners who are seeing patients day in, day out. There are the people that compile evidence. There are the people that pull, people like Rod who pull everybody together so that we can have a discussion about these things. So today was a great example of seeing the problem through different eyes. Every little talk you take away one little nugget. I mean, with Ken Sakaris's talks and his YouTube videos, there's always, you learn something new every single time. Even if you watch the same video again. So the reality is that, am I going to change my practice dramatically? Probably not, but I feel a bit more empowered. I feel the support of the community as well, and that shouldn't be underestimated because, sometimes it is very lonely in general practice for me. I close the door and I have my patient in front of me, and sometimes I question my own sanity more than I'd like to admit. And sometimes, you sit there and you go, well, am I saying the right things in the right way? And certainly, listening to Mary and Lucy, for example, you just get these ideas about how to do things better. So it is picking up little bits and pieces here and there, and it all adds up.
I echo what Arj just said there. As a registrar, I have a supervisor, and as a junior registrar, my supervisor was Arj, so I knew that I was well supported to practice low-carb medicine, but I'm no longer at his practice. And this week, I'm presenting to the 5 doctors who'll be working that day on a topic of my choice, which of course will be low-carb medicine. And I don't know what their opinions are yet. I don't know if any of them practice it. I've certainly not stumbled across any of their patients that have been coached through that way, though I have seen a couple of patients at that clinic find me, and I do promote myself as a low-carb interested doctor, and they've never questioned me on that. So for me, the encouragement and support of everyone in this room and the latest evidence, and I took photos of all of the most recently, the most recent articles, so that they're the ones I can provide to my esteemed colleagues on Thursday when I present them with this way of managing their chronic disease patients. So thank you.